This lecture is about the language of the skin exam. I'd like to define and describe the terminology of skin lesions. I'd like to briefly discuss special and vascular lesions. I want to practice how to describe and document skin lesions. I want you to analyze a dermatology case study, which is polymorphic eruption of pregnancy. And actually, we're not trying to diagnose it. I already gave you the diagnosis. It's about learning how to describe and document it. So, morphology, that term, it's just the common language used to describe a skin lesion. And I think it's important because we have to know if that skin lesion is either primary or secondary, okay? And then, of course, there are some special skin lesions and vascular skin lesions. But right now, let's just take a moment to talk about primary and secondary lesions. So primary lesions arise from normal skin. They're really an anatomic change in the epidermis, the dermis, or the subcutaneous tissue. And look at those examples, from macules all the way to tumor. What description actually qualifies a macule to be a macule is that it's less than 1 centimeter flat, like a freckle. So I've given you the qualifiers and examples. A secondary lesion is a lesion that results from changes in the primary lesion. So when have you ever seen a nodule or a papule ulcerate and turn into an ulcer? Often as a nurse, I'm sure. So those secondary lesions result from changes in the primary lesion. And it's important for us to be able to say, hey, this is a primary lesion. No, this is a secondary lesion. So I gave you two visual examples of primary and secondary lesions. On the right slide is a patch, a primary lesion, and this is unfortunately vitiligo, where the melanocytes are affected and the coloration in the skin is absent. And you can imagine on a person that has this profound of a change, that would be pretty devastating. On the left is a secondary lesion, and the one that I provided the visual is a scale. And in this particular case, the person had vesicular lesions, and they ruptured and started to dry, and they left the patient with a secondary lesion or a scale. So the one thing in this slide that I want you to understand is that there are some categories. So certain diseases fall in categories, okay? So let's just take the urticarial category. And that has everything to do with hives. And our case today actually is considered a form of an urticarial category. But I just want you to know that not only can certain disorders fall in categories that can lead to our diagnosis, but there are several lesions that actually have more than one descriptor. They can be a macular patch. They can be macular papular. They can have vesicles and bullae, and they're considered vesicular bullous. So just remember that often we use descriptors because they are more than one thing. Color is so important. It's such a clue, but we've got to be able to describe and document the color because it often correlates with pathophysiologic changes. So in terms such as hyperpigmentation, hypopigmentation, those are to describe lesions that are darker and lighter than the patient's overall skin color. And of course, that's individualized for your patient. Erythema and erythematous are terms used for red hues of lesions, and those are primarily due to dilated blood vessels in the dermis. But look at those other colors that are often seen in dermatologic conditions. And now let's not just look at them, see some examples of what they could possibly be associated with, because that also leads to your diagnoses. Size and margins. Those are also important descriptors. So most sources use lesion diameter of either a half or 1 centimeter as kind of their category, but you can really use any measurement of size, okay, to discriminate between lesions. I actually use millimeters in your case today, okay? So then probably one of the easier things to recognize is margins. So are the margin of the lesions, are they well defined or are they ill defined? And that's also a clue for diagnoses. We are required to palpate, or should, in a good physical assessment, most lesions. So we're looking for consistency. Is it firm, soft, hard, fluctuant, or board-like? Deviation in temperature. Is it hot or cold? Today's case study is hot. It's very warm to touch. Is the lesion or rash mobile? Is there any mobility or is it fixed? And that can also be a diagnostic indicator. We're looking and assessing for tenderness. And we're trying to estimate the depth of the lesion or rash. Is it dermal or subcutaneous? Shape, arrangement, or configuration. And look at these. It's really defining shape and how they're arranged or configured. And there is specific language for dermatology. So has anyone ever seen a geographic tongue? That's a map-like topography on that tongue, which normally indicates nothing. It can be a normal variant. But often you'll see when people don't feel well, they might have an exaggerated geographic tongue. Annulars in a circle. So a lot of our ringworm that we see, we describe as annular. Reticulated, lace or net-like, and there's some viral rashes that reticulate. And so again, I'm telling you, these descriptors help you diagnose, and they certainly help us document accurately and competently. So let's just look at those shape and arrangement of lesion examples. And this is very, very brief, but I just wanted to give you some examples. So if you're going to see someone with eczema and it's in a perfect, almost perfect circle, you might think of nummular eczema, nummular, a Latin term for coin or round. And you can look at these examples, okay? Targetoid is a huge shape or arrangement that can put in our differential. Erythema multiforme is often presents with target-like or targetoid lesions. I wanted to visually example the dermatomal configuration of herpes zoster. You can visualize the dermatomes. We learned those in nursing school. And just recognize that some lesions fall into dermatomal descriptors. And herpes zoster is one. Look at these gentlemen. Herpes zoster is 99% of the time unilateral. And I've never seen it bilateral. Another cube. Arrangement and distribution of lesions. Again, dermatomal is included in this chart, but this is just helping you recognize they can be grouped or discrete or isolated, linear, reticular, photo-distributed, just on that sunlit exposed area. So recognizing that's also important in our diagnostic venue of what are we dealing with here. And then distribution. You're thinking of two things. The extent of the distribution, is it isolated? Is it localized, regional, generalized, universal? Or is there a pattern to this distribution? Is it symmetric or is it unilateral like the herpes zoster? Is it exposed areas only or the site of pressure, follicular localization? Is it random? Or does it follow dermatomes? Again, I hope you see that these are prerequisites into dermatologic, really diagnoses. When you understand these descriptors that we are using for the rash or the lesion. So I just want to point out there's some special lesions. I'll give you for one that fall into a category of erythema, okay? Erythema nodosum is so interesting. It usually presents as red nodules on the lower extremities, can be on the upper extremities, and often correlated with the initiation of oral contraception in a young woman. Not always, but often. Telangiectasia is a vascular lesion, and I'm going to show you a visual example. Bruising is a special lesion, kind of falls in its own category. Hematoma, which is a large bruise. And so just to be aware that there's this category of special lesions that might not follow the normal descriptors, as I've mentioned above. I gave you a couple of visual examples of a spider angioma and a telangiectasia and the definition. So, are these lesions vascular in nature? There's really not that many vascular lesions, but there's certainly more than appear on this slide. But recognizing those handful of vascular lesions could improve the outcome, the health outcome of your patient. So, let's get to how to describe and document skin lesions. We've already gone over a few things. The morphology, is it primary, secondary? What's the color? The margin, is it well-defined or ill-defined? The size, you measure it, or you give an approximation. Palpation, looking for consistency, temperature change, mobility, is it tender? And the number of lesions, their arrangement and patterns, and the distribution of the lesion. So keeping that in mind, let's look at this case study. We got a 26-year-old female, 4 weeks postpartum. She presents with a 6-day history of a highly pruritic rash. She said it started on her lower abdomen, where her stretch marks are from pregnancy. It has now spread to her lower back, legs, arms, and upper chest. The only thing she can think of that was unusual for her is that she thought she was getting a fever blister last week, so she took 2 grams of Valtrex orally. She also takes a daily prenatal vitamin, and she says she has no other symptoms. And if you'll look within your PowerPoint, I gave you her past medical history, her HPI, and her vital signs, okay? So let's look at our criteria I told you to use. The type of lesion, the color, the margins, the shape, size, consistency, arrangement, distribution, and location. And so I matched these with those 7 things, and I wrote down for you. This is a maculopapular lesion. It's erythemic. It's well defined. They're oral and oval. They're 2 to 12 millimeter in size. It's warm to touch. Multiple lesions, actually too many to count. Symmetric, it's on both sides of her, confluent in areas, and disseminated on her upper chest, arms, legs, abdomen, and back. So, and here's a photo of her leg, which looks a little different than her abdomen, where the striae are. So this is how I wrote this for my chart. It's a maculopapular erythemic, non-blanching, defined, round and oval, 2 to 12 millimeter lesions. The lesions are warm to touch. They're multiple, too numerous to count, symmetrical and confluent and disseminated on the upper chest, arms, legs, abdomen, and lower back. You ought to be able to follow this same type of patterning when you look at a rash or a lesion. Not just patterning, but descriptors. And that those descriptors lead to diagnoses. Matter of fact, they're really mandatory for diagnoses. So we'll have some more practice later in the week. Thank you.